session, we have invited Curdin Conrad from his professor at Lausanne University in Switzerland to talk about what I think is also something that we will discuss in the future, long-term remission, inflammatory memory, and even disease modification. So please, Curdin.
So thank you, Lars, for the introduction and invitation. I am actually here, so if I'm not, getting any syncope or whatever, I'll give you the talk. So these are my disclosures, and as Lars just said, I mean, stairway to heaven, can we actually achieve a cure, or are we really at least able to, in the future, modify the disease course? And we have some clinical observation that actually lead into that direction, and this is one of these. Some of you had a similar observation. There is a patient actually entering a study, this case secukinumab. She was treated for a year, excellent response, complete remission. After years, she needed to do a major dental surgery, got off the drug, and this is actually her 2 weeks ago, 5 years after discontinuation of any therapy, and she's in complete remission ever since. And obviously this we cannot explain by the half-life of the drug or anything else. So there is something has happened in her during her treatment that made her such a good responder and the maintenance of response. And one observation also that came from the clinic is that these are patients that usually have a shorter disease course, and this led to some clinical studies which looked actually into this and looked for how are these early, not early response, but short disease patients actually responding to the ones which have a longer disease duration. And this is a study from Germany where they compared actually patients with a disease less than 2 years with a disease course for longer than 2 years. And what I've seen is that actually the patients with a shorter disease course have a much faster response and a better response than the one which have a longer disease course. And the same holds true if you look at the ones which actually are taken off the drug, so withdrawal from the drug. Patients which had a PASI 100 were taken off the drug, and here you can see that about 6 months after the last injection, still 50% of these patients maintained the PASI below 1, so almost complete response and complete remission. And actually the predictor again was short disease duration. So it seems like that the shorter disease duration, moving forward, here we go, has a better and faster clearance. You have a higher rate of clearance, and you also have a higher probability to keep this effect for a longer period of time. So, and to understand that, you have to understand how a recurrence actually occurs. And we heard a bit about these memory T cells, which then actually reoccur or drive again the disease. And we know now it's a T cell mediated disease. We heard an excellent talk from Chris Griffith, and we know that in particularly these Th17 or TC17 cells. And for a long time we thought this is a central memory. So these are the memory T cells. They go back into the lymph nodes and the spleen and get reactivated from there and then actually recirculate to the skin and activate the immune system there and drive psoriasis. But we have fixed drug eruptions where you have a response always at the very same spot. And if you do an allergy testing, it's positive within the skin or within the previous lesions, but it's negative outside. And psoriasis usually comes back at the very same spot in the same patient. So it seems like this idea that the central memory is alone the one driving disease seems to be true. We cannot explain these things. And again, Chris also mentioned that this AGR mouse model or others showed that if you transplant skin from an uninvolved skin from a psoriasis patient onto the back of these mice, you spontaneously develop psoriasis in these lesions. And there's actually T cells which are transplanted along with this transplant. You can see them here before the transplantation, and they massively proliferate in the skin. They do not circulate through the system, but actually proliferate in the skin. And all these observations together then led to the description of tissue-resident memory T cells. Here we go. And we today know that we have actually more skin resident T cells than we have circulating T cells in the blood. We have about 20 billion T cells in the skin alone. And these tissue-resident memory T cells, they're defined by expressing, among others, CD69, which actually downregulates sphingosine-1 phosphate receptor 1, which is a receptor which drives tissue exit, so the cells can go back into the system. They upregulate, obviously, skin homing cells and downregulate CCR7, which is important for us going into the secondary lymphoid organs. But on top of that, at least some parts of them are also CD103 and CD49A or alpha-1 protein. These are receptors which are extremely important in the maintenance of these T cells in the skin, in particular the epidermis, and also the migration into the epidermis. And CD49 is actually almost exclusively expressed on CD8 cells and almost exclusively in the epidermis. So these are a subset of skin-resident memory T cells, which are actually very interesting, because if you block these specific T cells in this mouse model, you can completely block the development of psoriasis. So by really targeting the intraepidermal tissue-resident memory T cells, you block the development of psoriasis. So this was the first idea of confirmation that these tissue-resident memory T cells are the really key effectors in driving recurrency in psoriasis. And today we know that if you treat psoriasis, no matter how, if it's a biologic, as we heard later on in early talks about ditronol or phototherapy, you still have afterwards these tissue-resident memory T cells in there. They still produce some Th17 cytokines. And then you have a disease trigger, specific one or non-specific one. And then you activate locally in situ these T cells, particularly these epidermal T cells. You recruit additional circulating T cells, and you have the clinical relapse. So if you want to have a prolonged effect which goes beyond the drug half-life, we probably have to attack these tissue-resident memory T cells. We would have to eliminate them from the system to avoid any recurrency. So can we develop or deplete these skin-resident memory T cells? And we know that they are preferentially express IL-23 receptor, indicating that they need this signal to be active and be pathogenic. So could it be that by blocking 23 through guselkumab or another, that we can actually deplete these T cells from the skin? And that would be two options. Either way, it's so-called antibody-dependent cell-mediated cytotoxicity. That means that the IL-23 is still stuck to the receptor on the surface. The antibody binds, and then the T cell gets eliminated by a macrophage. This has never been shown in vivo, so most likely this is not something which is of relevance. So could it be that by just a lack of stimulus by IL-23, that the T cells are eventually moving out? We still do not have any data on that, if that is really true or if that has an effect. But what we do have is actually a clinical effect or tendency to do that, or that we can deplete the T cells from the skin by blocking IL-15. Now, IL-15 is more for Th1 cytotoxic T cells than Th17, but nevertheless, what John Harris showed in vitiligo, if you treat these mice with IL-15 blocking antibody, you can deplete these tissue-resident memory T cells and have a long-lasting effect in vitiligo. And interestingly, there are two mouse models, also in a xenograft and another one, that they showed that if you block IL-15 either by an antibody or soluble IL-15 receptor, you can block also psoriasis. So it might be an option to actually use these kind of drugs also in psoriasis. However, and this is the other side of the coin, these tissue-resident memory T cells, they obviously have specific tissue-specific inflammatory pathogenic effects, but on the other hand, they have a very, very important role in protecting us against pathogens, infections. And if by blocking 15, we eliminate the majority of our tissue-resident memory T cells, we're probably much prone to recurrence of infections as well, particularly viral infections. So this might not be the way to go. So is there another option? And one option would be to actually prevent that these tissue-resident memory T cells actually populate the skin. And that's where a lot of studies going into. For example, as I showed you before, the GUIDE study or step-in study from Novartis, which look into if you can actually intervene early, if you treat these patients early on, that they're not actually developing these tissue-resident memory T cells or just on a lower degree. There are some functional data out there, actually at the poster that we're having here at the SDR, but there's still no data if we're actually really depleting some specific tissue memory T cells. So I was talking about adaptive antigen-specific memory so far, and this is obviously, we know that this is T-cell mediated disease, but there's actually another component of disease memory, and that's the inflammatory memory. So what's that? And this has been shown particularly for innate immune cells, such as circulating monocytes, that upon a primary stimulus, you actually have in these monocytes, for example, epigenetic modifications, so there's histone acetylations or DNA methylations, and that leads to the training of these monocytes, so they can actually have a more important or a stronger response in a second stimulus. Interestingly, the stimulus is not the same stimulus or not necessarily the same stimulus, but they're just more prone to or trained to actually respond to any stimulus coming in. Or they can actually be the other way, tolerized. This we know from erythropoiesis patients, that repetitive erythropoiesis can actually decrease the response in these patients, so they can also be tolerized. This has particularly been shown by important for innate immune cells, but these innate immune cells circulating monocytes and so on, they are short-lived, so this disease memory is not that long. And recently, particularly Curdin and Elaine Fuchs showed that this is also true, in particularly for stem cells in the epithelia and particularly also the skin. So how does that work? In a very nice experiment in 2017, they showed that if you stimulate mouse epithelial cells with imiquimod as a first specific stimulator, you have the DNA, which is condensed early on, opens up, you have transcription factors, and these pro-inflammatory genes are then expressed. After a few days or weeks, all this gene expression goes back to a basal level, but you have some so-called memory domains or memory areas which remain open and much more accessible for transcription factors. And then if you get a non-specific secondary stimulus, and here they show through wounding, you have a much stronger response by these memory chromatin elements. And if you want to read up on it, it's just a very recent short review in Nature by those two, excellently written. It goes a little bit over my head, but I can guide you through a little bit. So the first response that they have here, which is specific, so the first one is specific, opens up the DNA. You have FOS here, which is specifically activated, and then the RNA polymerase, which then leads to transcription. So after the resolution, this remains open. You still have the enhancer here active, and then any stimulation that actually activates FOS will lead to an immediate promoter response and transcription, and you have this enhanced response. What is interesting, actually, that one stimulus that really was critical here, or was really one of these specific ones, was actually Th17. Through STAT3 could activate FOS and provide this first response. So it could be indeed that the Th17 response that we have in psoriasis is the driver for epigenetic mutations or changes in the skin of these lesions, and actually leads to this inflammatory memory in plaque-type psoriasis as well. We do not have any human data on that so far. However, and this is interesting, the step-in study I just showed you before is actually looking into that right now. So what we did, we compared patients with a new onset psoriasis of less than 1 year, compared the DNA methylation patterns of these patients with a chronic psoriasis to see if they actually develop more of these epigenetic changes, and then also if we can actually reverse these inflammatory memory in the early onset psoriasis as compared to the others. We do have actually the very first results in. It's still under embargo, so I cannot talk about it here, unfortunately, but I can tell you it does look at least interesting. So stay tuned on that one. That was a little teaser, but for my conclusions, what we do have, we might be able in the future to modify the disease by early intervention, because we can actually prevent the recurrence of the disease. And this recurrence is certainly in parts driven by these pathogenic skin-resident memory T cells, so we can attack those, or partially also by contribution of the inflammatory memory, which is driven by epigenetic changes, in particular by non-immune cells, in this case in psoriasis, by these epithelial stem cells. So early intervention might be the future way to go, actually, in our patients, at least in a subpopulation, and it will be seen or have to show if we actually prevent or reverse the skin population of these tissue-resident memory T cells, or if it is by reversing epigenetic changes. And with that, I'd like to thank you for your attention. Thanks.